I'll just briefly introduce exchanges in primary care. So actually, this is a platform that we formed a couple of years ago. So it was a dedicated series of structured insights from public health community and experts like you. And we bring together practitioners to share their experience. And we want to bridge the gap between theory and practice through these sessions and also develop our collective understanding. So for today's session, we have Dr. Sharmishtha. Dr. Sharmishtha is a doctor by profession. During her MBBS, she found her passion for public health and has been following that passion for almost 2 decades now. So welcome, Dr. Sharmishtha. And if you can just introduce what you'll be sharing today, and the stage is yours.
Thank you, Arpita. Just share. Okay.
You can see the slides.
Yeah. Okay. So good afternoon, everybody. And today we are going to talk about a project Angan, which is a project based on early childhood nurturing care. And we had done a pilot study in 49 villages. So I just would like to share it with you all. Project Angan, the acronym is the Anganwadi Approach to Nurturing Growth and Nutrition. The technical support given for this project was by SPACT, which is Surat Pediatric Association's Charitable Trust, and AOP, Gujarat, and Nutan Bal Shikshan Sangh, Vadodara, and it was implemented by Gram Sewa Trust, Kharel. Gram Sewa Trust was established in 1994 with by Doctors Ashwin and Harsha Shah, and started with a 30-bed hospital, which has slowly enlarged to 100-bed hospital with all the medical facilities, basic facilities, primary to secondary care facilities required in a rural area. Along with the hospital, we also conduct outreach projects in 63 villages of Navsari and Dang districts. These outreach projects are for health and for rural development activities. Starting from, say, womb to tomb, like we are doing different activities in the villages for women, for children, for adolescents, for geriatric patients, NCDs, mental health, etc. And rural development activities for women empowerment and education of children. So when we are working since 1997, we have been working in the tribal area belt for the improvement of malnutrition in the tribal children. Started in 1997, where malnutrition was very high. Over the years, we could bring it down to around 40% malnutrition, 45%. But later on, there was a plateau was seen. For last 8-10 years, we are seeing a plateau, and malnutrition is not dipping down. And so we thought we needed to do some new thing or new approach to decrease malnutrition. So that is one reason why we thought of Project Angan, because there was persistent malnutrition in the children. Another thing was, while doing that, we realized we were focusing more on nutrition and illness. And during this time, when we are thinking what approach should be taken to improve malnutrition in children, or go, more than the plateau, decrease less than the plateau, we came into contact with the Pediatric Association in Surat, and we came to know about Early Childhood Nutrition Framework by WHO. And that time we realized that we were working more on nutrition and illness, but our missing component in this was nurturing care. We were missing this component. And so we thought we needed now to strengthen the parental practices during early childhood for nurturing care of children, which may help us improve nutrition in the children. So nurturing care framework was adopted by WHO in 2018, and this was evidence-based they had, after many evidences, they had adopted these 5 components. One was good health for children, which would have the components of quality antenatal care, postnatal care, immunization, etc. The other was adequate nutrition to the children, which would incorporate early breastfeeding, 6 months exclusive breastfeeding, and then the weaning foods after that. Then the third component of the nurturing care framework was responsive caregiving, where the parents, it was the thing was that parents should understand the need of the children and then respond to that need of the children. Early learning opportunities should be given to children. That was the fourth component. And fifth component was safety and security of the children. So these were the 5 components of nurturing care framework. That was good health, nutrition, early learning, responsive caregiving, and security and safety. So we thought we will work on these 5 components. We had also studied that in Jamaica, a study was done for over 20 years, which showed that early nurturing care in children less than 3 years improved their education by 5.6% and improved their income, adult income, by about 25%. Similarly, there was another study done in Sevagram, Wardha, which showed that early nurturing care, when given, could reduce malnutrition significantly. Swachh, an organization in Haryana, also tried early nurturing care, and they also showed improved awareness and nutritional status of the children. So we thought we should also try nurturing care and as a component of our malnutrition and see if it helps us in improving the nutrition of the children. Why early nurturing care is important? One, because child development begins in the womb itself, as we all know. All the physical development and with it, the neurological development, the social development, sensory development, even hearing development, everything, language development, everything begins in the womb itself. So it was very important that early nurturing care starting from the womb is initiated. This development is rapid. Around 85% of the brain development takes place by 2 to 3 years and 90% by 6 to 8 years. So it is very rapid in the initial years, and hence intervention should be in these initial years, which will help child development. Again, this is the most sensitive period because in this period, there are many, brain development is going on, synaptic formation is going on. So children need stimulations in this period, which will help their brain development. And these small changes will, if in this period, during this period, will affect them lifelong, will have a lifelong impact, which will be see in their cognitive, their emotional, their social, and general health development. So we had done a baseline study in surrounding areas in Navsari district, and we found that 70 to 80% of the parents were unaware of Mamta card and the developmental content in the Mamta card. 42% of the children, only the mothers were taking care of them. The other family members were not supporting the mother in the care of these children. Again, 42% of the children, the caregivers were just giving them food and looking after their basic needs, but not spending time with them or playing with them. 47% of the children were never told any stories by the caregivers. So this showed that there was a clear gap in the stimulation of the children and caregiving, and hence this needed to be addressed. So we thought our focus should be, 1, strengthening the capacity of the caregivers in responsive parenting, opportunities for early learning, develop opportunities and talk to them about opportunities for early learning. And another thing was support to the caregivers. Sorry. So we initiated a project in 13 revenue villages of Chikli block of Navsari district in Gujarat, containing around 49 Anganwadis with a population around 35,000 and children 0 to 3-year-old around 827. 74% of this population was tribal. Majority of them were landless laborers and 80% caretakers were educated only up to primary or secondary levels. So our primary objective was to improve responsive parenting, promote early learning, enhance child safety, and identify and refer maternal depression. And our secondary objectives was better feeding practices, improve nutritional status, reduce illnesses, and increase vaccination coverage. To achieve these objectives, our strategy was one monthly parents and caretakers meeting. We thought that every month, parents and caretakers, we will conduct a meeting and discuss some topic related to child development and nutrition with them. Home visits and counselings to see whether the discussion of whatever topics that we are discussing are being followed and parents are being able to do responsive parenting. And also these home visits would help us to see care for the caregivers, sort of, if they have having any problems, if they are having any social or any other health problems, we can support them, which in turn will help in their care taking for the children. Child development assessment throughout this time, child development assessment to see what is the nutritional and developmental status of the children. And those children who need health support, refer them to the hospital or the district early intervention care center. And another strategy was capacity building of the field workers and collaboration with ICDS and health system and continuous monitoring and evaluation, and develop IEC material in local language. We had kept a 3-day intensive training for field workers where the pediatricians from SPAC and IOP had joined us in training the workers. After this 3-day intensive training, we also needed monthly 1-day refresher trainings for the workers. So every month over these 2 years, we are conducting monthly refresher trainings where each topic is discussed in detail with the workers, and training of village health workers and Anganwadi workers was conducted. After capacity building, community engagement was done through village orientation meetings. Meetings were conducted in villages with community leaders, with villagers, panchayat leaders, teachers, Anganwadi workers, health staff. All those available in the villages meetings were conducted with them, and it was discussed why the project was started, how it will be conducted, and what support is needed from them. Monthly parents and caretakers meetings are conducted by workers. Nearly 66 meetings are conducted every month by our workers in villages. And through these meetings, we use flip charts, nutritional demonstrations of different activities, and we also use WhatsApp messages to connect to parents who are not being able to come for the meetings. Home visit and counseling is an important component because it helps to give us individualized guidance to each and every family and parents. and also to observe feeding and interaction of the parents with the children or caregivers with the children. The key messages are reinforced and also helps us to support the caregivers in any way needed by them. We conduct Bal Vikas Melas in the villages. The objective of these melas is community awareness and active parent and community participation. So different stalls are arranged for different topics like childcare, nutrition, toys, locally made toys, safety of the children. All different topics are stalls are made on different topics, and parents, all the community, they are discussed. These topics are discussed with them. They visit these melas, these stalls, and topics are again discussed with them. Throughout this year, we also conduct child assessment to see their growth monitoring, their developmental screening, and for early identification of any illness and referral. We also taught parents how to make low-cost, locally available toys from locally available materials. This promotes play, parent-child bonding also, creativity, and stimulation for brain synapses development. So parents were taught how to make toys from locally available materials and which toys will help in stimulation of brain development of the children. The focus over here is stimulation or toys since the birth of the child. Since the child is in the cradle till the child starts sitting, crawling, all the toys have been developed depending upon the age of the child. During these meetings, we convert different topics like growth and development, importance of the first 6 years in child growth and development, what is responsive parenting, what is the importance of touch, talk, and play with the children, serve and return method of interaction with the children, nutrition and feeding practices, hygiene and infection, safe physical emotional environment, how to use the MCP card, developmental disorders and how to identify them, child sexual abuse and POCSO Act, sleeping time, screening time, storytelling time, first aid and Heimlich's maneuver for children. So these were different topics that were covered during these meetings with the parents. And I see material was also made on these different topics. The impact of these nurturing practices that we saw, that where just around 50-55% family members were supporting the mother in feeding, now nearly 80-90% family members are supporting the mother in feeding the child, where only around 58-50 caregivers were playing with the child. Now around 98-99% of the caregivers are playing with the children. Where around just 50-58% caregivers were taking the child for a stroll. Now around 78-79% of the caregivers are taking the child for a stroll. And where just around 50% were nearly telling stories to the child, 49-50%. So now around 80-90% of them are telling stories to the child, which help in their growth and development. Nutritional status, the impact on nutritional status, we saw that in 2022-23, when we started this project, about 65% children were normal in nutritional status. And as I said, this was a plateau. Last 8-10 years, we were having nutritional status around 60-65% normal. But in these 2 years, it increased to around 73% children who were normal. And even mild to moderate children was decreased significantly. We also compared these children with the children of with other 50 Anganwadis of other area, and we saw that the children, number of children with normal nutritional status in Angan area was 73, nearly 73%, while in non-Angan area it was about 66%, 67%. There are some feedbacks of parents who we have taken, and it's in Gujarati, but they are saying that there is increased awareness, and now they are interacting more with their children. They are making toys at home, and family members also support them in the child care. Sorry. This was also another case which was showing that there is increased awareness, better, they have improved interaction with children, they are more confident in caregiving, and important thing was decreased screen time. They have decreased giving mobile to the children. During these 2 years, many challenges were faced, and one of them was important was the concepts of early childhood nurturing care are new and complex and very difficult to teach the workers. Generally, our workers are just primary or secondary educated women from the villages. So it is very difficult to teach these concepts to our women. It is very difficult for them to understand and grasp this concept. And then again, understanding these concepts and talking with it with the villagers who again are have low education. So that is a very difficult thing, and we need to just what we tried to do was decrease or divide these concepts into very small topics, and use as much as examples and use as many pictures possible, and use very simplified language and local language that they may understand and try. But still it was a very difficult thing to do. Again, Anganwadi workers are overburdened with their work, so they help in mobilization of people, but it is difficult for them to conduct this whole thing, training or meetings on their own. As usual, generally fathers go away for work. They may go in the morning, come late in the evenings. So fathers generally don't attend these meetings. And hence, after realizing that fathers don't attend, we had started sending the WhatsApp messages and videos and information, IAC materials through these WhatsApp messages. Again, our people who are agricultural laborers who are working with whom we are working, and seasonal agricultural work reduced their attendance. Migration also occurred after monsoon, which was hence difficult to get all of them for the meetings. Other challenges were like meetings had to be limited to 12 to 2 p.m. when the mothers come from work and they are at home, but still, because they are just come from work and they have to cook or they have to eat food and then go back again. So they are in a hurry, and it's difficult to get time for them to attend these meetings. Many families lack smartphones. So those who cannot attend and don't have smartphones, we cannot send WhatsApp messages to them. Hamlets are very remote. So if we had thought 50 Anganwadis, 49 Anganwadis, so 49 meetings per month. But then we saw that there were some hamlets which were attached to one Anganwadi but situated many kilometers away. And mostly grandparents or the mothers, it would be difficult for them to bring the children to the Anganwadis. So then we started conducting meeting in these remote hamlets also. And lack of vernacular videos good quality vernacular videos to teach us workers, to teach parents. This is one big problem. We really need to make good quality videos based on early childhood nurturing care to teach the children, to teach the women. As I said, low literacy in the community, it becomes difficult to explain the concepts. We are thinking one is to simplify these concepts further and go ahead, increase father participation and develop vernacular audiovisual aids if possible to help us in continuing this and strengthen the community champions and scale to more villages if possible. So I conclude with the sentence that investing in early childhood development is one of the best investments a country can boost to make economic growth, promote peaceful and sustainable societies, and eliminate extreme poverty and inequality. Thank you.
Thank you so much, Dr. Sharmishtha. Thank you. Uh, it was a very good presentation and very informative. I would like to open the floor if there is anybody else who would like to go first with the questions. Otherwise,
May I ask?
sure, please, Dr. Kasim.
Yeah, thank you so much for your presentation and really important and relevant work. I work in rural Maharashtra, and I know it's a fact across the country that mobile phones are used as pacifiers nowadays in as early as 5 6 months infant. So this is really meaningful work. Ma'am, I just wanted to know if the videos you have created, I mean, it may be in Gujarati, but is it available anywhere on public domain? Hmm.
No, they are not available on public domain, but we can share the videos with you. We have some videos on nutrition. Most of the material that we have prepared is like flip charts and games, which the parents, which the workers can use to teach the villagers. Because again, showing videos in the villages is a bit difficult many a times. Yeah.
Is it available Marathi, Sharmishtha?
No, not in Marathi.
Sevagram has used, no?
Aram, yes. Kusum, uh, Sevagram has made some vernacular videos of has IC materials because they had started this project as Aram in Anganwadis around their area. So on
Okay.
YouTube, I found few videos of Aram, so I can share that with you.
Sure. Thank you so much. Thank you.
Dr. Kasim. Dr. Sharmishtha, I also had a question because we have a similar model. I mean, we don't work with Anganwadis as such, but we have our Fulwaris, which are daycare centers. And they are run in villages which don't have good access to Anganwadis. And I think the context is very similar because even we have like limited father participation because they migrate for work. So we've also been trying to engage fathers more. And I just wanted to understand what techniques are you using now to engage like fathers? What kind of messages are you sending on WhatsApp to increase their participation? And another question was, is there any link between attendance and in Anganwadis uh, and any correlation between attendance and the improvement in nutrition that you're seeing? Because that is something that we are trying to track.
One thing, Arpita, what we are trying to do is, as I said, we send WhatsApp messages to fathers. So these include small clips, video clips. They use small reading materials that the fathers can read, and everything is based on early child nurturing care. Another thing is when we personally visit the villages, we talk with the fathers when we visit their homes, and we try to convince them to attend some meetings whenever possible. Then when we have these Bal Vikas Melas, this is a huge event, and generally we try it at a time when the parents, and it's non-agricultural work, so parents are at home. So we try to ask them to come for these melas. And what we are seeing is ki, yes, those parents, nutrition, we have not tracked it down, but we are seeing that those parents who have attended regularly, they have started interacting more with children. They have stopped giving mobile phones to the children. Their children, they themselves, Shaky, our children are now much active than what they were before. So that is there.
And the correlation between attendance and the improvement in nutritional status.
We have not tracked that. We have not correlated that attendance
Okay.
and nutritional status.
Okay. And like Dr. Kusum mentioned, we will also be interested in understanding the kind of games and basically community
Yes.
engagement tools that you're using. I think
Yes,
it will be
yes.
very helpful for us
I
also.
will. We have made one training module, but it is in Gujarati. We can see whether we can translate it or do something in English. So maybe different people in different states can use it. Yeah.
Yeah. I think even if the Gujarati one is available, we can obviously adapt
Sure.
it to our context.
Yes.
But because we're also doing like early childhood development is something focus area for us also. We've also started focusing on it in the past year. And we also realized, I think, when the children went to schools after from the Fulbaris, the teachers also mentioned that they were more participative, they were the more active ones amongst all children. So I think, yeah, I think what you're doing is really going to reap a lot of benefits, and we would like to work more on it together also. Um, any other questions? Dr. Milind, do you have any questions?
Yeah, it's a nice presentation, but it was really great insight I'm getting. The more challenges like uh, how we can integrate this community with the family itself. It's not on our part. What we are doing is okay, but if as a community involvement is there, in a particular community, they are all of them should be made responsible for one family or something like that, and we can guide them. So as far as this engagement with the, because the other challenge is the financial challenge in the family itself. So we have limitation in supporting them with other things, but finally it comes to the family itself. So the people are engaged in how they can earn their livelihood. Like in Manrega, this the government has put off budget from Manrega, and it has affected families at a very large scale, especially in tribal areas. This is what I have learned. So how we can empower them with this employment and other things, including the mother or the father, both can have some employment where they live. Some kind of activity where the child is concerned. So it's because I've seen it is a kind of community responsibility as well, besides helping from our side.
Thank you.
Yes. Yes.
Yeah,
Thank you.
thank you.
Thank you. Yes, it is a community responsibility, and that is what we have been trying through our Bal Vikas Melas, trying to talk with the community leaders. This is a community responsibility and this is required. But what you suggested is good, and we can really see at community level what can be done. Thank you.
Sharmishtha, you mentioned maternal depression was one of the indicators that you were also looking at. So,
Yes.
and we're also trying to integrate mental health into our services. So, can you just share any insights you got through that?
Generally, actually, Arpita, what has happened, we have been working in child health and maternal health since 1997, 98. And generally, every year that we see that one or two, we see cases of maternal depression in these villages that we are working in these cases of depression. And our staff is actually has been trained over a long time to recognize these signs and symptoms, and then they bring these patients to the hospital, and they are being treated by the psychiatrist and the medical staff over here. So this year, in these last 2 years also, we found few cases, nearly 2, 3 cases we found, which were then they were counseled, they were brought to the hospital and treated and sent back. So out of them, I think now in 2 years, most of them have completed their treatment and they are doing well now, the mothers. Yeah. But again, the follow-up counseling is required, which we are doing because we also conduct a mental health program over here. And mental health is in these villages. So our workers have been trained in screening for mental health and then bring them to the hospital and then follow up for treatment and their rehabilitation, patients' rehabilitation. So we have been doing this work for a long time. That is why we added this as a component over here also, because when we are working with children 0 to 3 years, it will be easy to diagnose or screen them. Yeah.
And is there any particular tool that you're using, PHQ-9 or SRQ-14 or something like that?
No, for this we have actually prepared a local tool. There's an organization in Gujarat which has been working for community mental health since last 30 years. So they have prepared a tool in vernacular Gujarati language. It's a set of questions that we use via workers to screen.
Okay. Thank you. Yeah, thank you for that.
Yes.
Any other questions? Anything else you would like to add, Dr. Sharmishtha?
Hello,
No.
malnutrition and brain development is one of the important, but safety also one of the important. This our pilot is a mostly pilot study. We require to scale up more because only 50 Anganwadi we are just having a result. But
Right.
in our experience, safety also children, which is very also important. So there are many times children come with injuries which can be prevented very well. So this is also one of the important part of this program. But we cannot say this is only because of this developed, because it's a pilot study. We may come up after 5 years, maybe some concrete result. I think, Sharmishtha, we have to scale up
Yes.
this.
Yes, yes.
But
I think
still we are having a good result, so we like to scale up a good result. And I think it should be only not only malnutrition, but mental health, brain development, all are very important for the children development.
that's true. Any other points you would like to add from the study, Dr. Sharmishtha?
Yes, Dr. Ashwin Shah said that this was the pilot study, and we are really working more on it, and we would like to work and expand it to in many villages, because this was very encouraging for us. And we thought, yeah, this should be done. And as he said, safety is very important. All the components, these 5 components, we had been working on health and we had been working on nutrition, but responsive parenting, safety, these we needed to work more and develop more tools for these 2 topics. But it is very important because now what we are seeing, children are coming to the many times, what we saw, like coming to the hospital with injuries, which, as he said, are preventable. The knowledge is required. And again, also we needed, like when we were talking about safety, we had to speak with the parents about POXO and child abuse. And these topics were never discussed with them in the villages, never discussed. So this was their responses, and their were very different. They were very happy when these topics were discussed, and they came up with many personal experiences. When they were children, they had experienced child abuse, so these are the topics which are never in the villages. It's generally they think nothing happens in the villages, but child sexual abuse can happen in the village also, at village levels also. And so it's important that now we should not just concentrate on health, or not just concentrate on nutrition, but take all these 5 components and work whenever we are working with children.
The children to ingested so many tablets, iron. So it was our experience. So it's also important to keep the medicine where in the house. So it is very, very important. Snake bite, we have seen the children of 2 years, child of 2 years. So it is also important for the parents to have some use of safety mechanisms, all this. No?
I think I agree. I think usually safety is something that we all think about, but I think not very specifically. It is always spoken in general terms, but I think this is going to be, I think we will also be, I will also take this to my organization, and we'll also discuss, and we'll approach you for any guidance on this, because we've also started working on adolescent health, and the issues related to POXO and all are also coming up. And we were also trying to understand how to address the community on these topics, because yeah, these are very sensitive topics and you never know how it's going to be received. But I think what you said is quite encouraging for us also, and something to learn from. Yeah.
I think we should conclude then.
Yes, if there are no
Yeah.
additional comments, we can conclude. Thank you so much, Dr. Sharmishtha.
Thanks, Arpita, for arranging this, and thank you. Yeah.
Thank you everyone for joining. Bye.